many of you on this call were kind enough to be PI of a multi-center study that spanned over 4 years. And we have generated immense amount of data that is now being analyzed for submission for publication. So he's going to give you a synopsis of what has been accomplished so far. Karan, thank you.
Thank you so much for the opportunity to speak again. So as Dr. Parvizi mentioned, I'm going to be speaking about some of our ongoing studies, and I'd like to start again by just reiterating how thankful I am to all of the different sites, their coordinators, their PIs as well. Without their support, these studies would not be possible, and we're really grateful for all of their input. I've listed everyone I could think of, and I apologize if I've missed anyone, but thank you so much again for your efforts and support of the studies. So my aim for this talk is to run through the ongoing work and prefix each of the studies with the rationale for the inception of those studies. The first question, we've sort of discussed this with the prior talks, why Explore NGS? Briefly, one of Dr. Parvizi's prior fellows, Maj Tarabici, who I know is on the call, ran the first clinical specimen of an NGS at Rothman, and it was a culture negative knee case that was culture negative both at our institution and an external hospital. And we found that it isolated Streptococcus canis. It enabled targeted antimicrobial therapy. And so much, the patient did so well that they were actually featured in the local news. So our interest was piqued, and the next question was to evaluate the diagnostic performance between NGS and culture. We've already heard from Dr. Shahi about what we've published, but the aim of the ongoing work was to corroborate this signal in a multi-center cohort. And so the aim was to evaluate the utility of NGS for pathogen detection, particularly in culture negative, and see if the signal that we found upheld when we corroborated this across multiple centers. It was a prospective observational study, 14 different centers. The data I'm presenting today were just consecutive revision knee arthroplasties, and over a 2-year period of recruitment. We classified patients per the standard of care, which is the MSIS or the ICM criteria. And intraoperatively, we collected 3 different types of samples. There was synovial fluid, 3 different tissue samples, which were pea-sized specimens, and intraoperative swabs. Now, our sampling methodology has changed since the study inception, and I'll show you an updated video at the end of this talk. But this is how we sampled pea-sized specimens that were taken, for instance, from the canal, as well as intraoperative swabs. And this was based on work by Bill Costerton, sampling the largest surface area as possible, both proximal and distal to the joint. After sampling, the specimens were analyzed in 2 phases at the lab. First was a quantitative PCR, which wasn't really the focus of our study. The second was the full NGS sequencing, which was 16S amplicon targeted, with results available in about 3 to 5 days. The reports generated show the species as well as the percentage abundance and antibiotic projections, and these were shared with all investigators at all sites. Moving on to the results. There was no significant difference in demographics between the infected and non-infected cohorts. And the take-home really, at least in the revision knee cohort, was that patients that were MSIS positive and infected, but culture negative, we found that we were able to detect an NGS signal in about 90% of cases. And it was about 81.8% in the JBJS paper. So our multi-center data, at least in knees, does corroborate that signal. Also of interest, there was an aseptic group that were both single culture positive and NGS positive, which raises the question as to how accurate our gold standard is if we're getting positive cultures and NGS in those cases. But as was mentioned in the question thread, we did also find that there were aseptic cases that has positive signal in about 30%, and I look forward to the discussion about what we can do to understanding this further in terms of clinical implications. Looking at sensitivity and specificity, NGS had a higher sensitivity, but culture had a greater specificity at around 94%. And then we looked at concordance between NGS and culture signal. The majority were concordant, but there were 2 discordant cases where different organisms were detected on NGS and culture. And there were 5 cases that were culture positive, but NGS negative, 2 of which were fungal species that were later detected after we asked the laboratory to rerun at a lower detection threshold level. If we look at the organism profile, each of these graphs depicts 1 patient, and each column is a specific specimen type, whether it's fluid or swabs or tissue. What you can see is that there was good consistency across the board, irrespective of the specimen type. And the patient of sample origin explain more than 60% of the overall variation, which, according to the bioinformatics team that have helped us analyze this data, is significant in their experience looking at environmental microbiological subsets. And so these interim data do support the utility that we saw in the single center work for pathogen identification in culture negative cases, and support our single institutional experience. And it also supported this hypothesis that the majority of these cases, at least at the NGS level, were polymicrobial in nature, and perhaps this signal does escape detection on culture. But it also raises another question: is this signal actually relevant for treatment? And so, as we know, despite surgical management, our best efforts at surgical management, failure rates remain high in the literature, between 10 to 40%, looking at, depending on which papers you look at. And two main hypotheses are posited. The first is that these are vulnerable hosts, and that during the course of their treatment, a new organism causes reinfection. Whereas the second hypothesis is that organisms were present all along from the start of their diagnosis of infection, but escaped detection initially. And then due to antibiotic selection pressure during treatment, they manifested, either turned into a pathogen or were able to be detected on culture. And this is the persistence theory. So our aim for this particular study, which is again ongoing, was to use NGS to shed light on these two failure hypotheses and determine if that signal that we detect on NGS at the initial resection correlates with later failure. Again, we leveraged our multi-center collaborators. We're up to 635 revision arthroplasty cases, and it was a 2-year period with our 2-year follow-up data still being collected. Again, classified patients per the ICM MSIS criteria. It was the same sampling methodology and the same sequencing methodology. The difference for this study was that treatment failure was the outcome. And so treatment failure here at minimum 1-year follow-up was defined as a reoperation that yielded a positive culture. And we looked at the concordance between the positive culture at failure with the NGS signal at the initial resection arthroplasty. The take-home from our study flowchart here is that there were 203 infected cases, of which 29 failed. And in those 29 NGS positive cases that failed, 23 of them failed by an organism on culture that was present at the time of the initial resection arthroplasty, which was the equivalent of about 79%. What initially was concerning when we looked at the data was that on the aseptic side, so the ICM negative patients, 48% of these patients had a positive NGS signal. However, when we went further and looked at the failure rates, this NGS positive cohort that was defined as aseptic failed at a 10-fold increased rate compared to the NGS negative aseptics. And a similar rate of culture at failure present on the NGS signal at the initial debridement of these aseptic cases. There were several organisms involved in failure. I'm not going to go through each, but the 3 commonest were Staph epi, Pseudomonas, and Candidal species. And so this collaborative work, at least at interim analysis, does suggest that there is some utility of NGS, and that the NGS signal in both septic and aseptic cases may correlate with failure down the line with the organism detected on culture. But obviously we're waiting for the full 2-year follow-up data, and it remains to be known whether this trend will uphold on conclusion of the study. There are some limitations, and these are things we're going to explore in our final analysis. One is what antibiotic coverage was given in this observational study. Did we cover both gram-negative and gram-positive organisms already? And second, we need to assess whether the NGS signal in the successful aseptic patients is different, whether that is related to species or abundance or a different threshold. The next question was, with these ongoing studies, does NGS have any utility in other fields outside of joint arthroplasty, for instance, in fracture nonunion? We know that fracture nonunion is a devastating complication, and there's been some work largely based on PCR that suggests that a significant percentage of nonunions may harbor microbes that escape detection by culture. And so to investigate this further, we wanted to use NGS to see if we could identify organisms in non-union and compare rates with culture, as well as determine whether that signal detected on NGS had any role to play in further fracture non-union. To do this, again, it was a multi-center study. We've collected 45 non-unions present, excluded pathological fractures, and evaluated patients pre-op with a SED rate and CRP. The samples that we sent were 3 different types of tissue, so proximal, fracture site, distal fracture site and the superficial membrane, as well as swabs of the hardware and the fracture site as well, both sent for culture and for next-gen sequencing. In addition, we had a control group, which were acute fractures, closed fractures. And for this study, sorry, I neglected to mention, there were long bone fractures, so femur, tibia, and humerus only. And we also collected sampling field controls, so sterile saline from the table, reagent controls as well. And our primary outcome was radiological and clinical union within a minimum of 3-month follow-up, as determined by the attending physician. Our statistical analysis at interim, at least, involves concordance between the NGS signal and culture detection, as well as bivariate stats looking at fracture union as the primary outcome. This is an overview of our different samples that we sent from the non-unions and the controls. And the take home here was that even at the small cohort size that we have already, positive NGS detection does appear to be significantly associated with persistent non-union. Chi-square was 6.1 and a p-value of 0.48, apologize. And we went one step further and looked to see if the different groups, whether it was a control, a healed non-union, or a persistent non-union, could explain the bacterial diversity and composition. And there was again a significant difference with a p-value of less than 0.001 with respect to beta diversity. Again, going further and looking at an analysis of communities, we found, if looking at the heat chart on the right side, if you look at the third column, which is the persistent non-unions or the non-healed non-unions, the top 20 organisms are fairly red in nature and therefore enriched in the setting of persistent non-union. And they were less so in the healed non-union and obviously not in the control group of acute fractures. So even at this interim stage, we're quite excited about the signal and which organisms might be correlated with persistent non-union. So the fracture-associated microbiome does appear to be a risk factor at this early stage in the study, and we're very grateful to our collaborators. I know Dr. Conway and Dr. Natoli are both on the call. Thank you so much for your support, and we look forward to seeing if this signal upholds on conclusion of the study. Again, I'd just like to thank all of our centers for all the multi-center work. I'm just going to continue with the additional ongoing and future work that we're conducting to address issues with NGS. So following our discussion last week, we figured out that there are 3 issues with NGS: false positives, false negatives, and making the technology that's very analytically useful, clinically useful. So to do this, we've been working on some random forest and lasso modeling. What we did was we looked at, again, an ANCOM analysis to see if there were certain species that could predict diagnosis and failure. We identified 17 candidate species and then used lasso and random forest analysis to generate a predictive model through 1,000 iterations. And we found that our predictive accuracy, purely based on the NGS signal for diagnosis of infection, was around 75.8%. And we're hoping this will only increase and improve as we get our final results for failure and the two-year follow-up analysis available. Second, some of the feedback from PIs at the different centers was that it's difficult to interpret NGS results without biomarkers and a pretest probability. And so now in-house biomarker testing has been started. There's a synovial fluid CRP, a white cell count, and a neutrophil count. And this enables automatic reflex of NGS samples that might have a high pretest probability for infection in the laboratory, enabling a double extraction to see if there is a signal present below the usual limits that we clinically report. In addition, for ease of use at the physician side, custom tables are generated for each patient with a recommendation also for the antibiotic projections as well, and easy tabulating of an ICM score. Lastly, we've been again, feedback from the multi-center PIs was that the sampling when we were doing the study was quite cumbersome. It required physicians to turn away from the table, expose samples to potential contamination. The swabs that we were using were quite flimsy and not ideal for biofilm collection. So we took this upon ourselves to investigate it further. We compared different materials. This is a selection of 30 that we compared with respect to absorption and extraction efficacy. And the table here shows a surface area adjusted cycle threshold that we've shown here, and we detected 2 different materials that would be optimal in terms of the extraction efficacy. And then we looked at whether we needed a storage medium from the point of sampling to the point of analysis in the laboratory, which is typically about 24 to 36 hours before reaching the laboratory in Texas. And interestingly, a nucleic acid buffer was not needed and provided no increased yield in our testing. Once we've developed the swab with the appropriate material and the lack of a nucleic acid preservation buffer, we put it through the current standard, which is the M40A2, to make sure that it was not only useful for culture, for NGS, apologies, but also culture. And this requires testing through roll plate and swab elution methodology for 10 different organisms, aerobes, anaerobes, and fastidious bacteria. And this eventually resulted in a culmination of an optimized sampling methodology.
Swabs, 2 round tip swabs, a 50 milliliter vial with a screw capped top, a vial bag, and a Microgen Diagnostics laboratory requisition form. Step 1, collecting a fluid sample. Make the incision. Prior to arthrotomy, aspirate the joint and transfer the synovial fluid into the sterile vial supplied in the Microgen DX kit. Step 2, flat swab. After removal of modular components and to maximize the surface area sampled, use the first flat swab to wipe the surface of the implants, liner, and exposed bone. Place the flat swab tip inside of the 50 milliliter container. The tip can be detached by depressing the mechanism at the back of the flat swab handle. Avoid touching the tip of the flat swab. Step 3. Use a second flat swab and thoroughly wipe the medial and lateral gutters, including the posterior region of the joint, maximizing tissue surface area. Transfer the tip of the flat swab into the same specimen vial already containing the synovial fluid collected. If implants are removed and the intermedullary canal is exposed, use a round tip swab provided in the kit to sample the canal. A rotating motion in the intermedullary region is preferable. If more than one intermedullary canal is exposed, use a different round swab to sample. The round tip swabs can be placed into their tubing and included in the kit. They do not need to be added to the 50 milliliter vial. Step 4, collecting a tissue sample. Using a clean rongeur or appropriate surgical instrument, remove a small pea-sized amount of tissue from regions of the joint where infection is suspected. Deposit this into the same 50 milliliter vial used in steps 1 and 2. Place your completed Microgen DX lab requisition form into the front pocket of the provided vial bag. Add the 50 milliliter vial containing the sample material and round swabs into the larger pocket. Peel off the adhesive strip and press to seal the bag. Place the sealed bio bag into the
And lastly, I'd just like to conclude with really a plea for further support from all of our collaborators and future collaborators. We're starting now a study, a randomized intervention study that looks at outcomes based on treatment based on culture alone and culture plus NGS. We already have a few sites that are going to be involved, and the idea will be for us to have a panel of centralized infectious diseases attendings that will determine the optimal antibiotic treatment based on next-gen sequencing. I think this will be the best data that we will yield, and we're similarly doing a study in spine as well, and actively looking for collaborators if anyone is interested. Obviously, there are still hurdles that remain, but we're working on this collaboratively and hope to bring this technology further into the clinical arena. Thank you so much.